Our next speaker is Dr. Giselle Sholler. She is the Division Chief of the Pediatric Hematology Oncology, BMT, at Penn State Health. She is also Professor of Pediatrics and Pharmacology at Penn State University. She has received her bachelor's degree in chemistry from Concordia University in Montreal, her master's in microbiology and immunology from McGill University in Montreal, and her MD from New York Medical College. She is the chair of the Beat Childhood Cancer Consortium, a group of over 50 universities and research centers, where the research focus is on the precision medicine for children with cancer. She belongs to numerous societies and organizations, and her major focus has been in the understanding of the mechanism of DFMO in neuroblastoma. DFMO recently received FDA approval for use in high-risk neuroblastoma as a maintenance therapy in the treatment process. Her talk today is on the use of DFMO, when, where, and how. Dr. Giselle Sholler.
Thank you, Pat, and thank you for having me back here. It's been a few years since I've had the opportunity to be here, and I'm so thrilled to be back here with all of you again. So in terms of conflict of interest, I've been a speaker for US Rural Med. I'm not going to belabor this too much because this room knows the outcomes for high-risk neuroblastoma, neuroblastoma being the most common non-CNS solid tumor in children, occurring about 700 cases in the US each year, about close to half of those being high-risk neuroblastoma, and we can see the outcome is quite poor. So our standard of care for high-risk neuroblastoma currently has been induction chemotherapy with surgical resection, followed by consolidation therapy with single or tandem bone marrow transplant, followed by radiation, and then anti-GD2 and cisretinoic acid. The Children's Oncology Group landmark study, AMBL-0032, was the first to show a significant improvement in overall survival with the use of antibody. As we can see here, we increased the overall survival from 75% with retinoic acid to 83% at 2 years. This is a significant improvement in event-free survival. But as you can see from the curve, it's still pretty steep. In those first 2 years, still relapse occurs in about over 30% of patients within the first 2 years. And most patients historically with relapse, per this curve, as you can see, die. Our focus has really been on looking at DFMO as a possible mechanism to prevent this relapse within those first 2 years. So just wanted to step back and look at why do cancers relapse. Cancer stem cells are a small portion of the overall cancer. As you can see on the right, that little red cell is a highly tumorigenic cell that can, in and of itself, recapitulate the entire tumor. And then if we look on the other side, we see that those red cells, those cancer stem cells, are relatively refractory to chemotherapy because chemotherapy or radiation affects rapidly dividing cells by intercalating into the DNA, whereas stem cells are more quiescent and less rapidly dividing. And so they can stay hidden. When you're giving the chemotherapy, all of the other cells are being killed. The stem cell can remain and cause that relapse. If we can use a therapy that targets the stem cells, it's actually been shown that tumors can then shrink and resolve on their own. So how do we target these stem cells, these cancer stem cells? One of the important pathways in cancer stem cells is the Lin28 LET7 pathway. And in neuroblastoma, this is regulated by ornithine decarboxylase, ODC, and McN. We can see DFMO is an irreversible inhibitor of the gene ODC that's upstream of Lin28. When we inhibit ODC, we can suppress Lin28, increase LET7, and reverse that balance. There's been lots of research studies looking at Lin28 and LET7 in neuroblastoma. High Lin28 has been an expression in neuroblastoma, is a predictor of poor prognosis. Dr. Molinar's group in Europe increased Lin28 in mice and showed that it was able to form neuroblastoma tumors. So it's an important gene in regulating tumor formation in neuroblastoma. So we looked at the ability of DFMO And how does it affect all of these different genes? In 2 different neuroblastoma cell lines here at 48 and 72 hours, we were able to show that DFMO inhibits, decreases both LIN28 and decreases MECAN. And as we've been hearing a lot lately, MECAN is really important. And also other cancer stem cell markers such as SOX2 and NANAG are all affected by DFMO. We also looked at the effect of DFMO in cell cultures to see how does it affect the ability of cells to form tumors. So we did what's called a neurosphere assay, putting 1 or 2 cells per well in 96 well plates, and then treating with DFMO or not. Those without DFMO, where there's that 0, the red bar, was able to form tumors. And these are 5 different neuroblastoma cell lines. As you increase the dose of DFMO on those cells, they're unable to form those neurospheres. They're unable to form tumors in cell culture. So basically, looking at just the big picture, DFMO inhibits ornithine decarboxylase, lowers polyamines. It actually induces senescence. I didn't show that section of research. It restores the LIN28 LET7 balance and suppresses neurospheres, really leading to a cytostatic response of neuroblastoma. It's unable to form tumors. And that's in the cell culture in cell lines. What about in patients or in mice? One of the other important pathways, as we looked at that pathway, was the ability to the LIN28 overexpression leads to high glycolytic activity of a tumor. And we can see in the mice on the left, the ones above it's over different days. Up until day 32, we see high glycolytically active tumor. In that same mice that received DFMO, we can see that it's less glycolytically active. I'm sure many of your children have had PET scans, and that's really what this is looking at. This is a PET scan in a mice. It suppresses the PET activity, decreases the activity. And that's what we saw, and this is one of our patients from our phase 1. We can see on the left, after just 1 month of DFMO by itself, we saw that that patient's tumor became virtually PET negative. It decreased the activity of that tumor. So again, it didn't decrease the size, but it decreased the activity. I seem to have missed this. My mouse model seems to be gone. No, there it is. Okay. It's just a little bit out of turn. Okay, we'll just go back. So the phase 1 study that we looked at, that patient was really just looking at the very first time. Phase 1 is first in children with neuroblastoma, looking at the effect and safety, and looking for the safety of the most safe tolerated dose. So we looked at 4 different dose levels in patients with neuroblastoma. All the dose levels were found to be safe. We didn't reach a maximum tolerated dose because we were seeing effects at these dose levels. We didn't feel like it was necessary to continue to go up. The patients were receiving DFMO for 1 cycle by itself, and then in combination with low-dose etoposide for another 5 cycles, and then DFMO by itself if they were continuing to do well. What was interesting in this phase 1 study is that each of these children were told, oh, I'm going the wrong way, sorry, that they had about 6 months to live while coming on this study. Phase 1 trials, as you guys all know, are for children who have bypassed standard of care and any options, curative options. And so these kids came on the study with active disease, all of which are in college today. So this was really exciting. These kids are more than 10 years since DFMO and have not received any additional therapy since that time. That made us really look at what is happening with this. This was something that we had not seen in any of our Beat Childhood Cancer phase 1 trials, and we still haven't seen anything like that in other phase 1 trials that we've done. So again, we wanted to look at DFMO. Could it, instead of treating with active disease, could we bring it up front? Could we bring it earlier? Let's not wait for these children to relapse, and could we prevent relapse? And so this is a study that was done to mimic what our phase 2 would look like. We had mice, and we gave them minimal disease. So these are 2 different cell lines. In BE2Cs, we gave them either 10 cells, neuroblastoma cells, into the mouse, or 50 or 100. And then the SMSR is a little bit higher because they don't form tumors in mice quite as well as the BE2Cs. And then we put drinking water in the mice, DFMO in the drinking water for some of the mice, and just regular water for the others. And we saw the mice that had DFMO in the drinking water were not able to form tumors, whereas and those are on the DFMO side, on the other whereas if they just had regular water, tumors formed in these mice. So this gave us encouragement that could we prevent tumor formation by giving a continuous DFMO. So our phase 2 study started with DFMO to see if we could prevent relapse in children with high-risk neuroblastoma at the end of upfront therapy. So as we mentioned, the standard therapy that we've been giving to our patients, plus DFMO orally as a tablet twice a day for 2 years. During that time, patients were monitored with scans every 3 months for the first year and then every 6 months after that. And what we wanted to compare against was the outcomes of the AMBL0032 study. And you can see that gray bar at the beginning. That's the time where the patients were on antibody. And yet still at the end of antibody, at the end of those first 6 months, you can see the curve still continues to drop. And so our statisticians looked at the curve from the end of antibody out to 2 years and predicted about a 30% relapse without DFMO. And so the historical control there is where our prediction was, and we saw our patients had a significant 2-year and 4-year event-free survival at about 85 to 83%, still in remission. The overall survival was even more exciting, being 95% of our children still alive at 4 years. And so this was incredibly exciting. These results resulted in a breakthrough therapy designation and a lot of work with the FDA to really dive deeper into this data to see, is there a way to look at this even more closely? Could we find a fit-for-purpose external control to do a more statistically rigorous analysis of the data? Most of the DFMO patients who received DFMO on that trial had followed standard of care and actually been enrolled on the AMBL0032 study. And so could we use the data from that trial as, there were over 1,000 patients who were treated on that study, 80 of those received DFMO, the remainder did not. When we looked at we were able to receive all of the raw data from the Children's Oncology Group, which we were very thankful for, and did a comparison of the DFMO patients versus those on AMBL0032 that would have qualified to receive DFMO. So many of those, again, from that over 1,000, it limited down to 850 because the patients had to be in remission at the end of antibody therapy and meet other criteria that would have allowed them to enroll on DFMO. The selection rules resulted in very similar populations. And then when we looked at the entire group, we saw a significant difference in improvement both in event-free and overall survival. But then we needed to go even a little bit further. I'm not going to go too much into the safety toxicity data for DFMO today, but DFMO has 70% of our patients on the phase 2 study had no side effects, but there are some important side effects, one of those being our hearing loss. It's a reversible hearing loss, so important to notice if patients, again, it's about 5 to 10% of patients at this dose level. We are using DFMO at a higher dose level in a different study, and we are seeing an increase in the hearing loss at the higher dose. But in this one, it's about 5 to 10% of patients. Again, we do follow audiograms at 6 months and at a year. If hearing loss is noted, we do hold, allow it to reverse, and start at a lower dose level. That is primarily the most important one in terms of all of the others. We haven't really needed to change dose. We have seen bumps in liver enzymes that go back to normal while continuing it, as well as some dry skin that has used moisturizers primarily. But again, going back to the data, now we wanted to look even further with the FDA doing something called propensity score matching. Propensity score matching basically is important because it reduces biases when comparing patients from different sources. It matches groups of patients based on propensity scores to optimize the similarity of the two groups and balances covariates between the groups. Essentially, it takes one of our patients and matches it to 3 patients from the larger COG database based on the criteria on the left. We worked really closely with the FDA to identify what are the 11 most important criteria that would be important in risk and outcome for patients. And this was the list that was determined. before even looking at the data, how do we want to match these patients? And so this now allows us to take one of our patients and find 3 patients that are exactly like that one of our patients. When we do this, and we look at the patient characteristics, now they're almost exactly the same. Before they were close, but now they're almost exactly the same 2 patient populations. And then also in the green are all the covariates before they're matched, and we can see the standardized difference before. And then the blue is once the matched populations are all within a very close 0.1 of each other. So it really reduces the differences between the 2 populations. When we do that, this was incredibly important in working with the FDA, that the propensity score match confirmed the increase in event-free survival. Again, at 4 years, we have 84% of patients still in remission as opposed to 73% of patients. And the overall survival, we have 96% of children alive instead of 84% of children alive. And it was really this overall survival, these children, being alive is so critical, that allowed the FDA to really want to move forward with this and make this available to patients. We had a lot of discussions. Could we do a randomized trial? Given that the outcomes were significantly better than expected, everyone that was in the discussion felt is it even really ethical to put children into the risk group of having a lower outcome in overall survival. The new FDA framework allowed for regulatory approvals in rare diseases using single-arm studies, and because of the availability of the patient-level data from AMBL 032, this was just such a fortuitous event. It wasn't planned to be that way, but having that availability of that large database to be able to do such a direct comparison, not even a historical control, but a contemporaneous control, because these were the same patients on the same trial. We were able to, U.S. WorldMeds filed a new drug application in November of 2022. This led to an ODAC meeting, which is Oncology Drug Advisory Committee meeting in October 4th of 2023. This was, those were 4 things that were evaluated at the committee meeting. This was to, they bring in an advisory board, and then us as the researchers and the company present our data, and then the FDA presented their evaluation, all of the statisticians at the FDA and their work, and then a really open discussion. What was really moving at this was after the lunch, there was a 1-hour open public forum wherein many families filled the hour asking the FDA, telling their stories about their experience on DFMO, and it really showed the importance and the impact that parents and advocates can have. It's really emotional and moving. One of our children, actually, she's in college now, spoke for herself as a child being on DFMO and why this needed to be approved. So it's on YouTube if you ever want to watch it. It really was impressive to see how important your words were. And at the end of the day, the FDA wanted to, these were the 4 factors that were considered. Was this an appropriate external control? Was there an assessment of whether this was an adequate and well-controlled study? Was there did they establish substantial evidence, which is a single-arm trial with confirmatory evidence? And I actually talked to some of my researchers and lab folks because they looked at those mouse studies. They looked at the mechanistic studies that were done in the lab, because we only had one single-arm study, that the laboratory research, the confirmatory evidence, was part of the approval package and really important. And then with the overall risk benefit, we're fortunate that DFMO has very little risk relative to the benefit. The statisticians also did, and I'm not going to go through these, but a whole bunch of more sensitivity analyses. And each line, if it's on the left side, it means it favors DFMO versus the right. And you can see every way they looked at the data, they just kept trying to go more and more and more stringent. Every way that the analysis was done, it favored DFMO, increasing event-free and overall survival. And so then, at the end of the day, the question came to the committee that has the applicant provided sufficient evidence to conclude that DFMO improves event-free survival in patients with high-risk neuroblastoma. And then they put up this slide for about 10 minutes, which was the longest 10 minutes ever. And then we got the yes. And this was encouraging because when the ODAC is an advisory committee to the FDA, the FDA doesn't have to follow what the ODAC says, but historically, if the advisory committees have said yes, the FDA has always approved the drug. There have been cases where the ODAC has said no, and the FDA can still say yes. And that's 4 cases or so where that's happened. So the FDA voted yes to eflornithine, making this the first time the FDA has relied on a single externally controlled trial to support an approval in oncology. This was a big deal because some of it was 70% yes, but there was 30% that said no. More on the adult oncology side, that this is not how they do things. So iWilfin is really named after 2 of our 2 patients to represent all of the kids. Will was one of the first children cured with the DFMO from our phase 1, and Finn is the nephew of one of the VPs, Kristen, from US WorldMeds, which was really why we're thankful US WorldMeds came alongside with us to move this forward to the FDA. And it really shows that in pediatric oncology, we're so small that often it takes that personal connection, that personal touch, to make it important enough for the company to jump in and make this happen. So Finn is doing great, and so iWilfin is the name of the medication. And the indication is for high-risk neuroblastoma patients after immunotherapy. The way it's written doesn't necessarily say for upfront patients, which has been really nice in terms of regulatory and insurance approval for relapse patients. If you've had immunotherapy, then the insurance should, it follows along with the label, which is great. So in conclusion, for this part, the DFMO is cytostatic, it targets cancer stem cells, inhibits tumor formation, both in vitro and in vivo, and all of that work was really critical to obtain the FDA approval. And DFMO prevents relapse and increases survival in children with high-risk neuroblastoma. I wanted to mention just a couple of other studies. So as you know, I've mentioned that I've moved to Penn State Health, and we are, being at a university setting, there is an incredible amount of research happening in all of the pediatric oncology labs there. And from being there just 11 months, we've been able to initiate 4 more clinical trials. The first study that we'll be opening is a DFMO in combination with AMXT, which I'll talk about. DFMO, we are expanding into Ewing's and osteosarcoma, which is obviously not appropriate to discuss here, but that trial is coming up. And then we have 2 new studies, tipifarnib with naxitamab and a CK2 inhibitor. I just wanted to touch quickly because these are going to be opening relatively soon. So the DFMO in combination with AMXT, just wanted to share a couple of groups in Australia have done amazing work. We studied this combination back in 2013, but in our lab, but it wasn't quite ready had not even been in humans yet. And then some of the teams in Australia studied in neuroblastoma mouse models as well as DIPG mice models and showed significant improvement compared to DFMO alone in those models. Really, how this works is DFMO inhibits the polyamines inside the cells, but cells can also get polyamines from the outside and bring it in. And there's a polyamine transporter that does that. AMXT blocks that polyamine transporter. So combining the two, the neuroblastoma cells can't get polyamines inside because of the DFMO, and they can't get it from the outside because the AMXT is blocking it. So it completely starves the cells of that polyamines, decreasing the MECAN even further, decreasing the LIN28 even further. And so our phase 1 study is going to start, we have FDA approval, we have IRB approval, we're getting ready to start in August. It's going to be a phase 1/2 study. The primary endpoint of the phase 1 is safety and maximum tolerated dose. There's going to be, really our starting dose is 400 milligrams per meter squared BID of AMXT and 1 grams per meter squared DFMO. What's different about this study is that AMXT is oral medication, so the DFMO, when in the first in human study, when they did orally both, there was a lot of GI toxicity. So the DFMO is actually going to be given by a continuous IV pump. It's a little plastic pump for if any of you have ever had Vanco at home, or it'll be like that and changed once a week. So continuous DFMO, IV, and oral AMXT. There's going to be 4 different cohorts. The neuroblastoma cohort is going to be a randomized cohort because we know DFMO alone does have some effect. We want to see, so they'll be randomized 2-to-1 though to get DFMO and AMXT or DFMO. Because the primary endpoint is progression-free survival, if there is progression on DFMO alone, patients do have the opportunity to get DFMO and AMXT if they would like. There is the opportunity for the crossover because the primary endpoint will have been met. What's important to note on this study is that the toxicities of AMXT 1501, I'm not going to go into too much here, except that there have been cardiac toxicities associated with this combination in the adult study. Not at the dose where we're going to be starting at. It's that the next dose level later. But because of the cardiac toxicities, myocarditis, kind of fluid around the heart, and one heart attack in the adults. And then there was a DIPG patient that it's unclear at day 18 came in with loss of consciousness, decreased blood pressure, a lot of symptoms. Unfortunately, there was no autopsy or workup done, so the question is possibly was it cardiac versus herniation. The patient was a DIPG patient that had been progressing while coming on study. But there is that question, was there a cardiac event there as well? Blood work wasn't done and autopsy wasn't done. So we're going to watch really closely. We've had a lot of conversations with the company and with the FDA, and so there's a lot of monitoring, echoes, heart CPKs, and troponins on that study. Again, the first dose level, we don't expect to see a significant, that dose level seems to be safe in the adults, but at the higher doses. It's such an important combination in terms of what we see in the animal models and the mouse models, and can we make this even better? We want to have the opportunity to look at it, but there is a toxicity. Again, this is the pump for the DFMO administration. The next trial that we're opening, and we just received FDA approval for this study, is a combination of naxitamab with tipifarnib for relapsed refractory neuroblastoma. This is really exciting. There was a question earlier about what could make antibody more effective. Well, Dr. H.G. Wong at Penn State studied this combination with tipifarnib is a farnesyltransferase inhibitor. But what it's really doing is improving the immune system in the cancer to allow the antibody to be more effective. Neuroblastomas secrete these extracellular vesicles that induce resistance to immunotherapy. These extracellular vesicles block T cells and NK cells from getting into the tumor microenvironment. So the tipifarnib blocks these extracellular vesicles, allowing those T cells and NK cells to be there and to be able to be active in helping the immune system fight the cancer in and of itself. And then when you combine it with the anti-GD2, and the immune system is much stronger. And so when he one of his experiments, again, I'm not going to go into all of the preclinical, using C57 black mice treated with either vehicle dinutuximab alone, tipifarnib alone, or the combination, and we can see over to the left that the combination of dinutuximab and tipifarnib almost completely eradicated the tumors. The tipifarnib alone had some effect. Dinutuximab had even greater effect. This is all being repeated with naxitamab. The reason that we elected to use naxitamab in our trial is that naxitamab is outpatient. A lot of our centers now have quite a bit of experience with the naxitamab. It's given on day 1, 3, and 5, 1 hour, half hour, half hour. Much easier to do as an outpatient so the kids can be home. The tipifarnib is an oral medication. And so here the subjects are going to receive 28-day cycles with tipifarnib twice a day on days 1 through 7 and 15 through 21, with naxitamab on days 1, 3, and 5. So it'll be completely outpatient for the kiddos. there'll be a safety run-in for the first 6 patients. We don't need to test the tipifarnib dose. There is an established dose in pediatrics, and we're going to use the established dose that has been used, and then combine it with the established dose of naxitamab. But with the first 6 patients, we'll just confirm that it is safe to give together. And then that'll expand into the primary endpoint being to evaluate both of these based on overall response rate and duration of response. I have a lot of conversations with the FDA recently on this combination, and they feel that this is potentially, if we can show an improvement in both overall or significant overall response and duration of response, that this potentially could lead to a registration study. We're also going to look at safety and tolerability and measure PFS and OS. So this is, we did receive, again, FDA approval in July. It's at the central IRB right now. This one we expect to open likely in September, October. The final new study that we have is looking with a CK2 inhibitor. This is at the FDA right now. We should get the answer from them back August 2nd, next Friday, about this trial. This is, CK2 is important in many biological processes in cancer. This drug is actually currently in study at St. Jude for medulloblastoma, and we want to bring it into neuroblastoma as well. At the bottom, 4 different studies, 4 different groups looked at expression of the CK2 and neuroblastoma correlated to poor outcome, showing that this is really an important pathway. Just in general, the overall study design is going to be a phase 1 for all solid tumors. So not only neuroblastoma, but sarcomas, et cetera. And then once we have the safe and tolerable dose, we'll split it into 2 phase 2s, a phase 2 for neuroblastoma and a phase 2 in Ewing sarcoma. We have preclinical work in both of those. These will be combined, so it's just the phase 1. Neuroblastoma will be combined with irinotecan and Temodar, and then the sarcomas will be combined with vincristine, irinotecan, Temodar. The cycle 1 will be the DLT period to identify to look at that effect, the dose, to identify the dose for this, and then once we determine the recommended phase 2 dose, we'll move into a phase 2 again with those same chemo combinations. So just in looking at the Beat Childhood Cancer trial openings for this year, the DFMO MXT, as I said, we received FDA approval in June. It will open, it essentially is open, but we'll hope to start enrollment in August. The BCC, the tipifarnib and naxitamab, we received FDA approval July, and we expect to open in September. The CK2 inhibitor, we expect approval by Friday, and will open in October, and then the Ewing sarcoma and osteosarcoma will open early next year is our goal. So we've been busy. It's a great group. I'm thankful for all the patients and families that participate in our research and all the advocates that help this move forward. This really, Beat Childhood Cancer is really primarily funded by families, and we're so thankful for all of the belief that you have in us and to make this research happen. I'll take any questions, and sorry if I went long. Okay, yeah, so the question was, do we envision using DFMO with not high-risk patients? We have used it in intermediate-risk patients that have been refractory on our expanded access program, so patients who were thought to be intermediate risk and yet were refractory or relapsed after intermediate risk. In those patients, we've not designed a trial for that. That's sort of been one-off. Definitely not in the low risk, but I think in the intermediate risk, there may be a role for certain patients, and I think trying to understand which ones would be a good thing, yeah.
Okay. We'll do one here and then come back here.
Hi.
Hello.
Oh.
Can you elaborate a little bit on the DFMO in combination with AMXT as far as how long that trial lasts?
Yes, it's so in terms, it's up to 2 years of treatment is the plan right now. So we're really looking for progression-free survival. So until there's progression, or up till 2 years would be the maximum time point.
So then you would stop at what point would you decide to stop that trial? Because you said it's up to 2 years, but it's as short as.
So for the patients, it's until they either progress or they make it to 2 years.
All right, thank you.
Yeah.
I have a question about DFMO now that it's been FDA approved and it can be written off the shelf.
Yes.
For a patient who may have had DFMO years in the past, did well with it, but has had subsequent relapses, how could DFMO be used again? And if so, how long can it safely be taken for?
That's a great question. We have had patients who have been on DFMO for 2 years, off, and then relapse, years later, and have gone back on it. We don't know necessarily how long is safe. We have had children who have relapsed on DFMO and relapsed only in the brain, and the standard dose of DFMO is not high enough to reach through the blood-brain barrier. Looking at PKs, we do need about a 3 times higher dose. So the standard dose is 750 to 1,000 milligrams per meter squared. So for some of those patients who then did relapse in the CNS and had surgical resection, radiation, and we have been able to put patients back on at the high dose DFMO and complete 2 years, and have done fine, because that's the dose that does reach that area that was not being treated prior. So I would say the longest we've had a patient on is probably up to 4 years, but it's, we don't have long-term data in terms of safety.
Okay, and I did have one other question about the BCC020, and that's just for treating active disease, or but not for remission.
It can be for relapse patients who are back in remission, and we were going to follow for PFS.
Okay, all right, thank you.
So the discussion of vaccine versus DFMO was very actively discussed in parents' community in the past few years. So I'm curious to hear your opinion with this FDA approval. Do you see a place for 2, maintenance therapies in the long run? How do you view?
Yeah, DFMO decreases relapse by 50%. So we know we're going from 70 to 85% staying in remission, but that's still not good enough. We need 100% staying in remission. So it would be really interesting to see a study with the DFMO, with the vaccine. Could that even push it? We need to fix that, still that extra 15%. That's part of the, we're looking at DFMO and AMXT. If we can find a safe dose, could we use that to help? But vaccine would be another way, or the CAR Ts that were presented earlier. We're not quite there yet. It's an improvement, but not enough.
Thank you.
Okay, thank you. In regards to the pathway that the DFMO is disrupting, we know that it disrupts the McN, but in regards to kids who have other amplifications or mutations, do any of these fall within that same pathway, such as ALK patients or anything else that may have that under control already?
Yeah, no, but we have treated over 10 patients with DFMO with lorlatinib in combination. The 2 are very well tolerated together. Actually, Finn, who you saw there, received 2 years of DFMO and lorlatinib. So we are combining the 2 together if the patient does have an ALK mutation, because I think it's important to target that one as well.
Okay, and it's important to continue to target both of them even after the ALK is negative?
That's what we have been, Okay. We don't have a control arm to say no, so.
Okay, thank you.
Yes.
Okay, over there.
This might be a little similar to that question, but I'm going to ask it in a slightly different way. But are there any certain disease attributes where you have statistically different outcomes for DFMO, where it's either much more positive or much more negative? So think about if you were able to get your kind of Curie score all the way down to 0, does that make a difference in terms of positive versus negative? Or the McN amplification, is that more positive, negative, just from kind of what you've seen from the results?
We have looked at the McN amplified patients do slightly better, but not significantly different in terms of the statistics. But both groups do equally as well. Again, MECN maybe a little bit even better than the not MECN, but both improve in their EFS. Our bioinformatics team is actually looking at one of our studies right now for patients who had genomic sequencing at diagnosis and then received DFMO to look at what other markers, because I think that's important to see if we can subgroup the patients in terms of response.
And so for the 15% or so, were there any kind of similar attributes of those 15% that?
Not that I know of right now, no.
Got it.
You know, we definitely want to, yeah. We are trying to, in addition, kind of different to that question, but in terms of upfront neuroblastoma right now, in terms of the Beat Childhood Cancer Consortium, we are adding naxitamab to induction therapy. So we agree with earlier talks today that GD2 is important upfront. And we are doing genomic sequencing of patients, which will help us do those predictions later. Every child is getting full whole exome, whole transcriptome, and we're starting to do epigenetics as well. We're doing the induction therapy with naxitamab. Our group has felt that naxitamab is a little bit easier to give with chemotherapy, again, because it's just the 1 hour, 30 minutes, when you're giving a lot of other chemotherapy at the same time. It's not a randomized study, it's across the board. And then during antibody, we want to see, is bringing DFMO up front higher, earlier, even better, because we know that about 16% of patients still relapse during antibody. You know, so where everyone arm wears DFMO and antibody versus antibody alone, and then at the end, everyone is getting DFMO continuously. But yeah, I think a lot of those questions are so important, which is why we do need to be doing genomic sequencing for each of the patients to be able to tease them out.
Thank you.
Thanks.
Okay, one more question there?
I was going to say thank you for sharing the Beat Childhood Cancer trials that are going on. I was curious if COG is testing it in any way, and if so, what does that look like? How are they testing it with DFMO? And with it being FDA approved, there's not a lot of drugs that are FDA approved for neuroblastoma or pediatric cancer in general. Is there any chance that this becomes standard of care at some point?
Yeah, we do expect this to become standard of care. It is for all of our centers, and I understand that the Children's Oncology Group is in discussions with the company to add this to the end of their next upfront trial, given that it has been FDA approved for this indication. Sorry, the beginning part of the question was
What kind of trials is the COG?
Oh, yeah, so the COG has done a study looking, a randomized study of cyclotopo antibody plus cyclotopo antibody and DFMO, and we are anxiously waiting the readout. That's for patients with relapsed active disease to look at the difference in response rates. So yeah, so they're using it more in the active disease setting.
When's that supposed to come out?
Soon. The data, I think it's supposed to be soon.
Okay. Anyone else? Okay.
Thank
Thank you,
you.
Dr. Sholler.